So I would like to thank all speakers for their excellent presentations. I would like to invite you on the floor. We have 15 minutes for questions from the audience. So shall I start? So I would like to ask if we relate the two presentations by Professor Kolibianakis and by Dr. Tiras, how we could combine regarding the role of add-on experimental therapies. What is your view on that, Professor Kolibianakis, and then shall we start with Professor Tiras and then with Professor Kolibianakis? So if we relate the presentation from Professor Kolibianakis regarding what is an add-on, how would that fit in your presentation?
Is your question that how we combine them?
Yes. So regarding the role of an add-on, what is an add-on, how implemented into the clinical practice, what would your comment be on the PRP and on the exosome regarding the concept of add-ons?
Yeah. I mean, just let me say, all these studies are approved by the ethics committee of the university. So all these studies, published or non-published yet, approved by the ethical committee. So coming to combining two procedures, just we are getting PRP serum, like 5-6 milliliter serum. Then we've got the exosome. To having the exosome takes about 4 or 5 hours, and nearly same, about 6 milliliter serum we can have. And at the same time, we inject the ovaries of the patients at the same time. And then usually we wait 2 months to see the results.
Mm-hmm. Professor Kolibianakis, your view on...
Thank you, George. Well, science, I think it advances thanks to courageous men who decide to perform the appropriate studies to advance the field. That's the first point. The second is that, as I mentioned, my point of view is that until an intervention, such as the one we're discussing, crosses the field of research to the field of real clinical application, which offers safety and benefits to the patient, then it remains in the research context. Then it should not be offered as a standard treatment to patients, and patients should not be charged. That's my point of view. So we should make a distinction that today we do not have such evidence to offer this to patients who, of course, cannot judge if this is experimental or if this can be informed, but not necessarily can really judge about that. So it is us who have the responsibility to make the distinction and offer the patient treatments which are not proven yet in the appropriate context.
Thank you very much. Any questions from the audience?
I must say, thank you very much for the question. I think this is a really important question because it is very difficult nowadays, maybe in the past too, to make a clinical practice which you think it is based only on what is proven. Most of the times, you're going to fail, financially at least, because your intentions to help the patients are not really appreciated by the patients. The patients are excited with new treatments, are excited with doctors who think they're innovators instead of something else, which is the truth. And then, what is your point of view? I think it's a dilemma that all of us have to answer, and it is answered by drawing a line of professional dignity. And you must say, I'm not going to go beyond this line. And let's make it real. I'm not going to apply anything that I cannot prove to my colleague, to you, or to the patient, to a lesser extent, that this is really helpful. And if I'm not able to do that, because sometimes the evidence is not there, then I must explain to the patient that this is my opinion on the basis of incomplete evidence. And the patient must decide if he trusts, adopts the opinion of a doctor, which is probably the worst thing he can do, or waits until the evidence is there to apply. But this is, we have to explain to the patient. You have to make a distinction of what is our interpretation of the literature and what is the scientific truth that everybody agrees on it. It's difficult.
Yeah, I must say that I certainly agree with Dr. Kolibianakis. Is it good? Yeah, thank you. But we should have studies, some experiments, and if the patient knows that this is an experimental therapy and you have ethical committee approvals, then you can do some studies. So after this kind of studies, after randomized controlled studies, then we can come to a result. I think before come this result, we cannot accept or refuse this kind of therapies, like it was as the same as the add-on therapies that Dr. Kolibianakis really gave a nice lecture about it and asked some questions like, is ICSI an experimental procedure or the other things, add-on therapies? So I think we should do studies in other centers as well, multi-center studies, then we can come a conclusion.
Any more questions from the audience? Please, Professor Tolagis.
Thank you very much. Very interesting presentations. I would like to ask you, because I saw you have many studies, did your studies use any control group? I mean, we saw the intervention, which was the injection of PRP, or in that case, but was there a control group injecting saline or something like that in order to compare? Thank you.
Yeah, very good question. We didn't do that. We did PRP to both ovaries, but maybe in the future there would be a study design like that. In one ovary, you can do PRP or exosome or anything else, and the other one, by just mechanical, puncture, you can do, and then see the difference.
Please.
I don't know if Dr. Grassenthal is here, but I know he was running a study doing exactly this, injecting PRP in one ovary and basically saline or sham in the other one. Dr. Grassenthal. But I don't know if the results are back. I'm not aware of he presenting anything. He'll be here later today, so you can ask him this question. But the paper you guys did with the Yale group had issues. There was another paper that was published from Spain that also showed no difference, but also had major problems. They froze eggs over 2 cycles, and then the 3rd cycle, they did the eggs and then fertilized all the eggs together. So they lost at least 8% of the eggs from thawing into doing this. The problem with your prospective study is they froze the PRP for a while before thawing it and using it. And for PRP, you really have to use it within 5 minutes. If you activate, and you really have to use it very quickly afterwards. Otherwise, we don't know if it's still valid and active after you freeze it for a long time.
We have
Can
many
I-
questions.
can I?
Please.
I just want to mention, I saw in your slides that Kissinger is not finished yet with the study, but he's still recruiting with difficulty, but he's still recruiting patients. But I saw in your slides that your population in some studies was patients with POR, poor ovarian reserve. And in theory, if you take patients with poor ovarian reserve, these patients, by definition, they have oocytes and they ovulate. So some of them will have a chance to become pregnant without any intervention. So if you have such a control group, as Professor Terladze said, then it's predictable, due to the low incidence of pregnancy, you will find no difference. If, on the other hand, you don't have a control group, then you take their worst cycle, the cycle that had no oocytes at all or very few because they didn't become pregnant, and then you would certainly show an improvement. This is very well known for any intervention. I think the design you described, the ovary versus the other ovary, is the design which is the ideal one, provided that you have ensured, I don't know how, safety for the patient. Because then there are no confounding factors. Regardless of the patient characteristics, regardless of the stimulation protocol, regardless of the person who does the pickup, the transfer, it's the same for the patient, because all the confoundings have gone. And if you choose a population that has not seen menstruation for 1 year, so they're postmenopausal patients, this is the ideal population to show that this intervention works. I don't know why we do it in patients who still ovulate, because there will be confusion for sure. So why don't you do it in patients who have not seen menstruation for a year or have FSH of 60 and amenorrhea of 6 months, whatever.
Any more questions from the audience? Professor Zegias, can I ask, in order to change subject, how would you explain the difference in euploidy rates within the same age groups between infertile patients and donor and oocyte donors, as you showed?
No. I have no explanation for that. I'm just curious, and I think we need to look forward more into our infertile population. And my only understanding is that being infertile is a more complex disease than just not having babies, and that it can carry from the youth many other small conditions or pathologies, which at the end make them infertile. But we are seeing only the tip of an iceberg of women that have many other conditions that will not only affect their capacity to procreate, but also other functions. And I think we need to look much more into that. And I'm very interested in how artificial intelligence can teach us, but not looking at the data that we can produce with IVF, but looking at women as themselves, irrespective of their fertilizing capacity or their fertility potential. And we must not forget that a few years ago, a few millions of years ago, women and men needed to be attracted. And mating had a purpose, which was to perpetuate the species. So it was very important to attract themselves, females and males. So there must be many other genes involved in being reproductively efficient. And we should try to look at those genes, where they are, where in the eyes or in the smell, or where can they show themselves, so that the female can tell the male, I am reproductively efficient, and so the male to the female. Those are the things that artificial intelligence might help us look. And then we collect the eggs and we can study what are the specific factors. But I'm very interested in getting that information somewhere.
Thank you very much.
You imply that donors are more attractive than infertile patients. Yeah.
But we have to define attraction first, which is not that easy.
And with this, I think we should go for all of us for lunch. And thank you all for attending this session. And we'll see you back at 2 o'clock for the next presentations. Thank you all. Thank you.